Hello, everyone. My name is Carrie Thibodeau, and I'm the National Director of Programs and Public Policy at the Kidney Foundation of Canada. Welcome to the last session of the 2025 Forum, Preventing Kidney Disease in Young Adults, Exploring the Impact of Mild Kidney Function Decline. Remember that, as always, any information shared in this session isn't intended to be medical advice. We always recommend that you speak to your doctor about your own individual situation. And now it's my great pleasure to pass the mic to our moderator for this session, Julie Wysocki, who is the Kidney Foundation's Director of Research.
Thank you, Carrie. It's my pleasure to introduce to you our first panelist today, Dr. Manish Sood. Dr. Sood is a nephrologist at the Ottawa Hospital, professor of medicine and epidemiology at the University of Ottawa, senior scientist at the Ottawa Research Institute, and Department of Medicine Research Chair in Physician Health and Wellness. He completed his undergraduate degree at Carleton and Lancaster University in the UK, followed by medical school, internal medicine, and nephrology residency training at the University of Toronto. He began his career as a clinical nephrologist at the St. Boniface Hospital in Winnipeg, Manitoba, and was recruited to Ottawa as the inaugural Schindel Research Chair in the prevention of kidney disease, a position he held for 10 years. To date, he has authored over 300 research papers, supervised over 40 research trainees, and has given over 100 invited lectures focusing on the epidemiology of chronic kidney disease, pharmacoepidemiology, and physician health using big data. He has received principal investigator grants from Canadian Institutes for Health Research, the Heart and Stroke Foundation of Canada, and the Kidney Foundation of Canada. He served on the Canadian Society of Nephrology, or CSN, Executive Committee as Secretary-Treasurer from 2019 to 2024, and founded and served as the Deputy Editor-in-Chief of the Canadian Journal of Kidney Disease and Health, which is the official journal of the CSN from 2015 to 2024. Welcome, Dr. Sood, and over to you.
Perfect. Thank you so much for the introduction. I'm very excited to be here and get a chance to speak to everyone today. I'm going to talk about the research that we've been doing that's very generously been funded by the Kidney Foundation of Canada, and it's a bit hopeful. And the idea here, what I'm going to focus on is, can we predict and prevent chronic kidney disease? So this is just some of my disclosures. There's nothing that's conflicting or perceived conflicts of interest with anything I'm going to say today. So an outline of what I want to talk to you about is, we're going to go into a little bit of the basics of chronic kidney disease and how it's defined. We're going to talk about why we might need tools to help predict chronic kidney disease. I'm going to introduce a prediction tool that our research team has developed that we call Predict CKD Lifestyle. And then I'm going to finish off talking about, can we prevent chronic kidney disease? And maybe this will require redefining or refining our current definition. So let's start, at the very beginning. As many of you may know, we determine if you have kidney disease or kidney problems based on a fairly routine blood test or urine tests. The blood test is the most common method of determining your kidney function, and that's measuring something called serum creatinine. This is a breakdown product of muscle. It ranges between 60 to 110 for most people, and this value in your blood goes up when your kidney function decreases. However, there's a lot of variability in creatinine. So in the way your nephrologists use this blood value is they convert it into something called an estimated glomerular filtration rate, or GFR. And many times we'll describe this as how well your kidney works. Normal value is greater than 90, and many times we'll even call it a percentage, like, oh, your kidney's working 50% normal, which is an eGFR of 50. How do we define chronic kidney disease? So these are the international guidelines, which all nephrologists in Canada, if not the world, follow. And if you look at the bottom here, we define chronic kidney disease in stages. And as I mentioned, greater than 90 for GFR is considered normal. 60 to 89 is a mild decrease, but really under 60 is what we call chronic kidney disease. That's the when we define it. And of course, it can get more severe as the stages show. And that's what really this slide is illustrating, is that the GFR less than 60 is the most common way we define chronic kidney disease. There are other ways too, but that's the most common one used currently. So knowing that background, we're going to use a little bit of clairvoyance and talk about, can we predict, and do we need tools to predict chronic kidney disease? Well, I would argue we do. And the reason is, among people without chronic kidney disease, awareness is quite poor. There have been a number of studies that have looked at this, and it's not surprising. Many of you know chronic kidney disease is, for most part, completely asymptomatic or silent. Yet many people come into my office, the first thing they say is, I'm surprised I have this. I don't have back pain. And again, this is the idea of maybe, we haven't done a good enough job to explain that back pain is very rare in chronic kidney disease. It's silent. And people with very mild levels of abnormal kidney function up to stage 2, less than 6% have any awareness that this is mildly decreased. Even among people who have stage 3, this is GFR less than 60, so say 55, it's around 6%. So we could see that really we need to do a better job as kidney doctors to make people aware of what chronic kidney disease is. And once we know that patients are more informed, they often will request more frequent testing. They'll be involved in informed discussions, and they'll have what we call knowledge-seeking behavior. All these things are empowering patients with their health, so they're good things. There have been studies actually asking patients and healthcare providers like myself, what do we want? What do you want to know? And what do you want us to study? And many patients say high levels of interest in preventative lifestyles or early therapies. And there is some evidence, some studies that have been done that showed that studies of fruit, vegetable intake, physical activity, losing weight, and less tobacco use can actually prevent chronic kidney disease. In another study where they looked at 63 patients in a focus group, diet and prevention were 2 of the 3 highest ranked priorities in chronic kidney disease. So this exercise, lifestyle, and education and raising the public profile of chronic kidney disease are key priorities for, I feel, preventing this condition. So using some of that background, how did we go about creating a prediction score or prediction tool that can incorporate some of these lifestyle factors to predict early chronic kidney disease? So we developed it, and it's called Predict CKD Lifestyle. So if any of you are familiar or look in the medical research literature, there's tons of prediction tools with chronic kidney disease. Most of them predict kidney failure or the need for dialysis, which, we feel is often quite advanced, and you may miss out on some prevention targets. We want people to not progress to that stage. So a lot of tools are predicting kind of the end of your kidney function, whereas relatively few are predicting the beginning onset of early chronic kidney disease. A lot of the tools that currently exist are also targeted towards physicians. So I will see you in my clinic, I'll enter your blood pressure, I'll enter some lab values, and out will come out some prediction score says 20% risk of developing chronic kidney disease. But there aren't any tools where we can just put them in the patient's hands and the general public can engage with them and predict their risk of developing chronic kidney disease from the comfort of their home, just using the internet. So we wanted to develop something using survey information. In other words, it will ask you provide information that most people are aware of themselves, and can that predict chronic kidney disease? And most of this will rely on lifestyle factors, habits, and diet to help predict it. So what did we do? Our research question was to develop an, like I mentioned, early CKD prediction tool that's developing a GFR of 60 or lower. And we wanted it to be for use from the general public with no medical knowledge, and it wanted to have simple survey questions to do it. So we were fortunate enough to have data to develop this tool. And there's something called the Canadian Census Health Survey, which is done roughly every 5 to 7 years on random groups of Canadians. So it goes across the country. And it asks them detailed information about their lifestyle, habits, their diet, physical activity, how they feel. And we took this data and linked it to health databases in Ontario where we got kidney function values or eGFRs. And that allowed us to look at 22,200 people who had completed the survey and we had lab values for, and we followed them for up to 8 years to predict how many would develop kidney function less than 60%. Our final model or things that we used in our prediction were age. I'll come to the second one in a second. Whether you're a cigarette smoker and how many pack years, how much alcohol intake you had, physical activity, diabetes, and when was it diagnosed, whether you have high blood pressure or active cancer. So some lifestyle, some medical history that we think most people would know, and some habits, we'd call them. But we knew that most people would not, say, have a blood pressure or a blood test and know their GFR. So we included a question in our prediction score of if you know your kidney function level, eGFR, enter it now. But if you don't know it, the prediction tool can work without it. And that was the recognition that we didn't think most people are aware or have that value on the top of their head. And using this, we did develop a very successful prediction score. We found that with quite a bit of accuracy, we were able to determine using those handful of variables whether someone will develop new onset chronic kidney disease. We further wanted to see whether this score could work worldwide or in places outside of, say, Ontario. And we found similar data in the England, in the UK, and we further tested it there, and it functioned and worked quite well. So what did we do with this prediction score? Well, we put it on a website that's free to use for anybody, and the website is called Project Big Life. So this is www.projectbiglife.ca. This is a website and a project created by a colleague of mine, Dr. Doug Manuel, and this has a number of prediction scores, such as how long will I live or life expectancy, what is my risk of having a heart attack, how much salt do I need to eat in a day. All of these are available here with what we would call very simple survey questions. And we added now, if you look in the very bottom, chronic kidney disease there. Will I develop a chronic kidney disease question? And it's been on this website now for a couple of years. And we've had tens of thousands of people predict their score and or predict their risk of developing chronic kidney disease through the years. So as you go through the questionnaire, at the end, it will give you a risk. So for example, this test case here gave 55% risk over the next 8 years. And then it mentions things that can be done to try to prevent this. Like this person had low exercise, so it was live a physically active lifestyle, and they were drinking a little bit excess alcohol, so it recommended to drink less. And then it visualizes it for you on the bottom, showing in the next 8 years, 55 people will develop chronic kidney disease out of 100 who were similar to you, and 45 will not. It further gives a little bit more detail on how to do these interventions like physical activity and how to drink less alcohol. And then, of course, it references kidney.ca for further information and results. And as always, it does mention if you're concerned in any way, to speak to your healthcare provider or primary care physician about this. So that was kind of our first part. We developed this score, and we hope people continue to use it. And if people can learn from it, it's a terrific way to engage and get involved with your health. The second objective we did was the idea of, can we not only predict CKD, but now can we prevent it? And what is a way we could prevent it? And we thought one way could be refining or redefining how we look at chronic kidney disease. So let's go back to the definition that I showed you. And if you look in the bottom left, remember, normal kidney function is greater than 90. Mildly decreased is between 60 and 80 to 89. Now, as a caveat, what does your doctor do if they get a value that's, say, 68 or 72 or 84? In other words, in this gray zone of 60 to 89. Well, there's no recommendations for what to do. It's completely unknown. And the reason is because we don't really know what happens to people who have values in that range. It hasn't really been studied. Furthermore, one of the main reasons we aren't sure what to do is because people's kidney function naturally declines with age. And this is a graph showing GFR on the y-axis and age on the x-axis. And what you can hopefully appreciate is, your GFR, say, is normal or high, or roughly around 100 as you're 50 or younger. But then as you approach 80, for example, the average GFR is approaching 60. In other words, the definition of chronic kidney disease. So this is a bit tricky because of this declining with age, we aren't sure what to do. Now, that's as you get over 50, or it happens sometimes in your 40s. But what about young people? Young people should have no gray zone kidney function. In other words, young people, like a 20 or 30-year-old, should have a kidney function of 100 plus. So it would be actually highly abnormal for a young person to have a kidney function level between 60 and 90. But the way we do things now is we don't really pay attention, or there's no guidance on what to do, because we don't know if there's consequences for a young person to have this slightly low level of kidney function. We thought this was an important question, so we tackled it. And the question we had asked was, in young adults, 18 to 39 years of age, does having a GFR between 60 and 100, so again, this is that gray zone, increase the risk of having a serious health outcome? And we define the serious health outcome as heart disease, death, or kidney failure. So what we deem significant events. So to study this question, we looked in a health database in Ontario where we had information on nearly 9 million adults. And we grouped them by age, 18 to 39, 40 to 49, 50 to 65. Now, I'm going to bring your attention to the graph below, and I'm going to walk you through it because I know there's a lot going on there. On the y-axis is your risk of having these adverse events. So if your risk is 1, there's no increase. If it's lower than 1, you have a lower than normal increase. You have a lower level of risk. Whereas if it's above 1, you have an increased risk. And then what we have across the x-axis is your GFR. And 120 is high levels of GFR, going towards the left of the screen, lower levels of GFR. Focus on the lines. So the lines represent each age group. And what you see in the blue line, which is 18 to 39-year-olds, is as your kidney function goes roughly below 90, it starts increasing the risk of having these adverse events. So even to 80 to 90, you could see the blue bar is slightly elevated, and then it keeps creeping up with lower levels of kidney function. This is 18 to 39-year-olds. The green and orange bars are the older groups, and what you could appreciate is it's quite flat in those groups until your kidney function, say, gets lower than roughly 70. Then you see it rise, but not nearly to the level of the 18 to 39-year-olds, the blue bar. So what we concluded with this is that in young adults, the risk increases once your GFR is less than 90. And it seems to keep increasing the lower it goes in this gray zone. It was consistent men and women, and we looked at a lot of different ways, and it was always consistent. Now, what's even more concerning about this was what happened or what the doctors did with this information. So we looked if the young person had a low kidney function, excuse me, how likely was it that they'd have a repeat test to check that it's, hopefully got better or not getting worse or whatever's happening. That's on the left-hand side of the screen and is represented by the blue bars. And what we saw is that even if your kidney function is between 60, 70, 80, 90, 90 to 100, it was roughly 40% of these young adults would have a repeat test done anytime after the next 3 months to 2 years. So, or another way of saying that is 60% didn't even have a repeat test. And we would think it should warrant a repeat test. A lot of these people with low GFRs can also have proteinuria or albuminuria, which leaks in the urine, which is another sign of serious kidney problems. And when we looked at those people, among 18 to 39-year-olds, the blue bars on the right side, even with low for expected normal kidney function levels, 80 to 90, 70 to 80, barely 5-6% were even having ACRs done. Furthermore, how many of these young adults were referred to specialists of any kind? It's very few. So nephrologists, 0.3%, endocrinologists, 1.8%, cardiologists, 1.9%. So we take away from this is that we've found that for young adults, having a kidney function test between 60 to 90, this gray zone, is actually quite detrimental. And because doctors don't really know what to do with it, they're not following it or checking for it or referring to specialists. So we're hoping by these findings, this can now hopefully alert physicians and raise awareness that this is something we should be checking. And what can you further do with this information? Again, I don't want to bombard you with some crazy graph, but let me just say this graph shows age across the bottom and kidney function measurements on the y-axis. And if you just draw your attention to, say, 30 years and look up from the x-axis and look straight up, you see some different colored bars. So the black bar represents, the dotted black bar represents you're in the bottom 10% for kidney function for 30-year-olds. And we provide in this graph the level. It would be 92.9 for your eGFR, and that would increase your risk of having an adverse event to 1.12 or 12% increased risk. Further, if you look down to the lowest bars, which are light blue, that's the lowest 1% of 30-year-olds. That would be kidney function of 74 or lower GFR. And that raises your risk to 1.6 or 60% increased risk for having an event. This is an age-based GFR kidney function graph. And we propose this as a way to help doctors identify that levels that may seem somewhat normal in an older person, 60 to 90, are not normal in young people. Why do all this? Well, aside from possibly talking to people and telling them maybe, improve your lifestyle, it can help prevent it if you're a young person with slightly low kidney function, we also have newer agents for the first time that are really changing chronic kidney disease, and these are the SGLT2s. So I just want to bring your attention to like the bottom left corner. If your kidney function is at 20% and you're put on one of these medications, from the research we've shown, it will decrease your time to kidney failure by about 1.9 years, let's say 2 years. So it saves you 2 years without kidney failure. Whereas Potentially, this hasn't been tested, but even potentially, if you give it to a young person who has a lower than expected level of kidney function, you could potentially buy them 25 years before kidney failure if the medication does the similar effect that it does for people in advanced chronic kidney disease. Now, I'm not advocating we should put young people on medications. I think that needs to be tested. But the point is, this data, the next thing it should be doing is say, hey, there's a problem here. We need to further test this and look into it. So wrapping up, in conclusion, CKD awareness can be improved. And I think it's nephrologists' jobs to do that. And we're very fortunate to have partners such as the Kidney Foundation of Canada who are getting the message out there. Patients want lifestyle-related advice on how to improve their health and prevent chronic kidney disease. Hopefully, we created a tool that incorporates some lifestyle factors that can be used by the general public in the comfort of their home to learn about chronic kidney disease, some of its risk factors, and they can do it with or without knowledge of their GFR. Young adults with mild levels of kidney function reduction are at risk of adverse events, and it appears to be the recognition of this among healthcare specialists is limited. Hopefully, identification and recognition of this will prompt more research into this area. Ours was the first study or big study to look at this problem. I'd say it's the tip of the iceberg. We have a lot more work to do. Age and risk-based graphs that show what normal eGFRs are for age may help improve recognition. So with that, I'd like to bring it to a close and thank everyone for their attention. I'd like to say a special acknowledgement to the Kidney Foundation of Canada as they have funded me very generously for both of these research projects through the years. Thank you.
Thank you, Dr. Sood, for the engaging presentation focusing on the prevention of kidney disease. Joining us today as well is patient partner Sean Delaney. Sean is a lifelong kidney patient whose condition arose from a blockage that was discovered in his first few weeks of life. Over a lifetime of walking the kidney journey, he has received 2 very generous living donor kidney transplants, first from his younger brother in 1998, and his most recent transplant from an amazing living donor in October 2020. Sean Delaney has over 30 years of experience working in the healthcare system, including the not-for-profit sector, hospitals, health regions, the provincial government, Canadian Blood Services, and most recently with the Alberta Transplant Institute. His last 18 years have been directly involved in the field of organ donation and transplantation through the development of national programs for the sharing of organs between provinces, including the creation of Canada's first kidney pair donation program and a highly sensitized kidney sharing program to share kidneys for Canada's most difficult to match patients. In addition to his professional work, he's also a major advocate for organ donation in his personal life and speaks regularly to conferences and community groups on the stories and opportunities for people to become engaged in this life-saving gift of life and the research that supports it. Sean, please tell us a bit about your story.
Thank you so much, Julie, and fantastic presentation, Dr. Sood. I think the universe is telling me something because this is the 3rd time I've talked to a relatively good-sized group in the last 6 months where the title had adolescents, pediatrics, or young adult in the right in the title. I am, if you can't tell by the gray, I am in my 50s and I am a grandparent to 2 now. I have to go back into the Wayback Machine to talk about my experience as an adolescent and a child. But yeah, as Julie said, I did start my journey as a kidney patient back in 1971. I was not peeing. I had a blockage in my urethra, which took out my entire left kidney and a portion of my right. I spent the first 9 years of life with a ureterostomy, so a bag off on my side, and which was then later reversed. But even in the 1970s, the word transplant was used if it was going to be needed. I think anyone who knows the history of immunosuppression drugs, you might not have wanted one right in 1972, it was a discussion all the way back there. And Alberta did its first, where I live, Alberta did its first one in 1967. So it was very, very new technology at that time. My growing up years, I think Dr. Sood's early slides said it entirely. Like, I mean, other than the fact that I had a bag on my side, I was asymptomatic, and I think my GFR hovered around 40 to 55 all through my growing up years, and so it didn't stunt my growth, which was, you know, a bit of a rarity for patients like me. I competed in long distance running and track and field, and hiked mountains and all these kinds of things. And I really didn't have. It's hard to tell even a kid who with a bag on their side that you have this, you know, life-threatening condition when you feel just fine. Your appetite is just fine. Your skin looks just fine. But there we were. Because of all the surgeries in those early days, my mom and I in particular, we had regular follow-up. I grew up in Red Deer, Alberta, halfway between Edmonton and Calgary, and we rode the train. There used to be, believe it or not, we used to have trains in the prairies. We had a dayliner that ran between Calgary and Edmonton, and we would ride it up to Edmonton and get on a bus, and that's how my checkups were done all the way through. So we know my GFR, we know my creatinine, and those kinds of values going back a long, long ways. And so I was really had the advantage of being flagged early, monitored throughout, and we did everything that we possibly could. And that little piece of my right kidney lasted till I was 27 years old, which is, you know, in some ways quite remarkable. But one of the big indications, despite the blood work, that I knew I needed to, the things were getting serious. I was an avid hiker, still am, an avid backpacker, and my brother, a friend of his, and I went and did a fairly rigorous 3-day hike up in Jasper National Park, up to an area called the Skyline Trail. For anyone who wants to look it up on Google, it's a beautiful part of the Rocky Mountains here. There was a point where I had no preconceived notion that I was not going to be able to do it. And on the final ascent above Curator Lake, look it up, from Curator Lake to the very top of Little Shovel Pass, I was collapsing. And my brother and his friend had to turn back and carry me the rest of the way up. So that was where really that feeling of symptoms and things like that really hit home for me. I was 26 at the time, and for my brother, that was his first indication of how bad things had gotten, and it was also there where he decided he was going to donate a kidney to me between his second and third year of medicine. So we were able to do a preemptive transplant. I avoided dialysis, and I had an amazing next 20 years. We had 2 kids. I have 2 grandkids today, and that kidney ultimately did decline as well. And you're monitoring it differently. With transplant, you're doing blood work all the time for drug levels and all the things. But again, that I was back in that cycle of after 18 to 20 years with the first transplant, and following those symptoms back down again. And so I went on a fairly extensive search for potential living donors again, family, friends, and things like that. I was harder to match now because I was now a version of highly sensitized. I had CPRA of 86% for Dr. Sood and others who speak CPRA. So not quite eligible for the very national system I had just helped to build, but still difficult enough to match just on a one-by-one basis with living donors. And after a humbling number of people came forward to get tested. We found a lady out of the blue who was a match, and I'm doing absolutely amazing. I'm coming up on 5 years with that, my second transplant now, and I will be kicking off my fifth anniversary will be October 7th, and I will be getting on a plane to hike the Camino de Santiago in Portugal and Spain to celebrate it and just take advantage of this gift of life that is absolutely worth celebrating. And so and despite this, my new donor, her name's Brenda. She is absolutely awesome. Being 40 to 50 pounds smaller than I am, I still am getting a GFR of 74 on my most recent blood work. So to me, that's pretty incredible to have that kind of function out of a kidney from someone who is smaller than me. I think overall, my background is actually public health. We didn't put that into my introductory bio, so I am all over the field of prevention. I would love to see people not have to go down this journey if at all possible. I love the idea of tools that can easily be shared out to help others. Anybody who knows me knows that I will probably say yes to my own detriment to almost any research study you want me to be involved in, because I think there's not enough of us around that are willing to step forward and take that extra step. It's not a huge time commitment half the time, but it can be very influential and helpful to research teams, whether that's qualitative research, quantitative research. I'm currently in a drug study. I'm in a cancer study, and I've done other ones in the past as well. So I think that's really important to me, and I'm excited to see SGL2 inhibitors and new medications and therapies coming on stream, because we've spent a long time without a new drug, really since I mean, on the transplant side, the implementation of tacrolimus was, a big jump forward for a lot of us. But in terms of the actual prevention side, I think we are absolutely overjoyed to see that there's been work in this area and it's showing promise. So I think that's great. I think I will close it with just one little piece on there, which is I get, because of all the hats I get to wear, I've been able to sit on a number of focus groups and even lead some with other kidney patients, with families and things like that. And this one fellow that I got to speak to in the last few months, he made the comment. He says, "What if this never had to happen to me?" And it's the simplest term and the simplest phrase, but for me, that underscores what can we do upstream with both web-based tools, with needle laboratory tests and things like that, to slow the decline or even stop the decline in kidney function for more and more of us, so that we can get longer lives with our existing kidney function.
Thank you so much, Sean, for your generosity in sharing your story. So now I'm happy to open the discussion so we can answer any questions you may have. And if you have not yet done so, please submit your questions by typing them into the Q&A box found in the Zoom toolbar at the bottom of the meeting window. And please note that we are unable to provide medical advice for specific issues. So I'll just check to see if there's any questions yet. Okay, I have one question. How can reductions in kidney function be slowed or stabilized with lifestyle changes? And what lifestyle changes can I make to keep my kidney function from worsening?
So maybe I could start that one. It's a terrific question. And I'll start it all by kind of putting a damper on it by saying the information isn't that good. The data isn't that good. And the reason is because it's really hard, and you'll see this. You're watching TV and on the news comes eggs are bad, and then the next day comes eggs are good, and then the next day comes eggs are bad, and you're like, what do I do with all my eggs? And this is the problem with studying diets and lifestyle, is you have to study them for long times, over like decades to see if they really have an effect. And it's hard. The ideal way to study this stuff is what we call randomized control trial. Well, people don't agree to be randomized to eggs versus no eggs. So it becomes very difficult. So with that preface of how challenging it is to do these studies, and there's maybe not that much great evidence around, there are a few themes that we see that improve from a diet perspective. The big one is fruits and vegetables. So an increase in fruits and vegetables versus processed foods is one. A decrease in salt intake, if you are susceptible, especially if you have high blood pressure, is another one. Weight loss, that's a big one. And there's a lot of strategies on how to lose weight, aside from just exercise and changes in diet. But now we have new medications that also improve kidney function or reduce kidney complications, the GLP-1s, or as the celebrities call them, Ozempic. Those medications are there as well. So weight. Then from the habit side, the big ones could be smoking especially, and alcohol intake, so excessive alcohol. Those are the biggest ones. Now, exercise, maybe not specifically to improve or reduce worsening of kidney function, but the major complication people have with chronic kidney disease is premature heart disease. And so exercise is the biggest way to tackle that, along with all the other benefits that exercise brings. So in summary, nothing exciting. It's the kind of same old, eat your vegetables, don't eat too many of them, and exercise and have good habits, which is easy to say and hard to do.
Thank you, Dr. Sood. So I have another question. Did you want to add anything to that question, Sean?
No, I mean, I think it's as simple as that. I mean, I don't know what set your own goals, whether it's 10 under control. If you have the real risk factors like diabetes and hypertension, do everything you can, if at all possible, to get those managed. And, drugs like Ozempic are helping with diabetics, and helping them from even getting further down the road where kidney failure is being discussed. So, yeah, I mean, it's eat right. I don't do it always. Exercise as much as you can. I don't do that all the time, but like do your best and try to focus on wellness. I think overall.
Thank you. Okay, so I have another question here. Were First Nations or Indigenous populations factored into the data for early detection of CKD?
Really, really good and important question. You can even say an epidemic of chronic kidney disease and kidney failure among Canada's Indigenous population. I didn't appreciate it growing up in Ottawa, training in Toronto, until I moved to Winnipeg. That changed and forever opened my eyes to the challenges that Indigenous people face with their health. So it's a good question. Now, there have been some studies that were done, mostly in Manitoba, where they went to rural First Nations communities and just screened everybody. So these were people who when we asked them or on a questionnaire, do you have kidney disease or do you know if you have kidney? And we don't really, let's even say we don't even know. But I think that really was an eye-opener to the risk for Indigenous people seems to be different. We don't know why. We can't put our finger on what it is. So in the studies that I did, the ones in Ontario, we don't have the ability to distinctly look Indigenous, yes, no. But based on some of these other things I've been involved in, I would advocate strongly that being Indigenous, once you become an adult, over the age of 18, having screening done is the way to go. See your family doctor, have checks done, give a urine sample, give a blood sample, and have your blood pressure checked. And that's just because it appears, unfortunately, the risk is just very high, and we don't know why. We have ideas, but we're not at exact reasons yet.
Thank you, Dr. Sood. So I have another question here. So There's been a lot of talk about smoking and alcohol. What about marijuana? Is THC or CBT safe in regards to kidney function?
Oh, I get it's all the interesting questions coming out. Sean, do you know anything on this one, or should I just pontificate?
I'm a non-smoker. Don't even look into it.
So it's an interesting question. So let's even break it down maybe. So one is the smoking, and let's say so smoking in itself is involved with all kinds of lung inflammation. So and sometimes the cigarettes, or sorry, marijuana can be mixed with tobacco. So again, that's got all sorts of issues with it as well. But let's assume you're using other forms. So, edibles and things. There, it's not clear. Now, those do have some effects, cardiovascular effects. So they, for example, do increase your heart rate. They may promote eating. So they have some other effects that may influence other things that can cause the kidneys to have some harm, but do they directly damage your kidneys even in the long run? No. As far as I know, and as far as the literature goes, the link is not there. And now I'll flip for a second. THC-based products, CBD-based products have actually been quite beneficial for a lot of people. And I'll give you an example. We have a lot of dialysis patients who have restless legs. They're losing weight because they're losing their appetite. They have anxiety and they have trouble sleeping. And I have talked to them about using CBD in this role because it treats all those things in one shot. Now, is that fully medically tested? And is there big scientific data behind it? No. But these are things that should be explored. And I think, future studies should look at this as opposed to maybe set it aside, which is kind of what society did for 50 years. It's bad, but I think now the floodgates have opened on it, and this should be looked at as potential therapeutic.
Okay, thank you. I'm sure that's good news for some people. Okay, I have a question for Sean here. Actually, Sean, why is it important to participate in research as a patient partner? What benefits have you derived by being involved in the research world?
Well, I'm a bit of an anomaly because I also work in the field and I'm a director of a research institute here at the University of Alberta. So I always have my own conflicts where I want to see research go forward because I also work in the field. I think, like I said earlier about, SGL2 inhibitors and things like that, I think we don't get to new therapeutics, without involvement of patients. Everybody has a question about marijuana use and kidney patients. What about marijuana use and transplant patients as another subset of that? And you can only explore those with willing participants, and sometimes willing participants who are willing to do randomized control and be randomized to a treatment arm or a non-treatment arm, and you won't know until the study is completed. So no, I think it's incredibly important because every one of us are in some ways test cases for the next generation. We're learning from every one of us as patients because we all bring something slightly different. We bring our gender, our ethnicity, our background, our lifestyle, all those different practices, and I just think it's important. I think the other one that has been really, really important, especially coming through the pandemic and things like that, is more on the qualitative side as well. I'm really sorry, Charles, I missed your presentation on the last session, but I can probably figure out some pieces that you were saying. Keep banging, buddy. We need to always be thinking about mental health as well. And there's a ton of research going on in the mental health. Any of us that are going down this road of a kidney journey, from the outset, it has a ton of unknowns. So I applaud everybody who's joined this trying to learn because you're early on in your journey. And I think every time we step into a new transition, me from a transplant failure to hemodialysis, which I've been fearing for 45 years, and then back to transplant and all those little transitions through that journey, I think we need to know, how big a deal is depression and anxiety and suicide and all these kinds of challenges within the kidney population, and B, what are the best treatments, whether that's drugs or therapy or mentorship groups or whatever it is. We can only do better for the next generation. And so, I mean, I'm 53 now, and so I'm not quite at the full look back stage, but I definitely can see. I got to speak at a conference, sorry, at a kids heart transplant camp back in the fall, and for me, it was very, very reflective for me to see kids just entering this journey, and the parents and caregivers who are just entering that journey, and seeing that they were looking after themselves very differently than my mom and dad and I probably did, in the 70s and 80s, because we just know more, and we know more because of research and because of clinicians and academics who have dedicated their lives to helping us.
Thank you, Sean. Okay, Dr. Sood, is there any research on vegetarian diets and prolonging kidney function in CKD?
I like this question. It's a good question. Let me just start by saying in general, people who are vegetarian are universally healthier than those who are not. Now, exactly why isn't clear, but they have reduced incidences of cardiac disease and certain types of cancers. So the veg thing is there. Now let's flip for a second. In the old days, we used to recommend that patients who have chronic kidney disease not or restrict their protein. And this is antiquated knowledge now. We don't do that anymore. The idea there was if people who have chronic kidney disease have some protein leakage, if you eat protein, does that cause more protein leakage and cause strain on the kidneys, and it can worsen it over time or quicker? But we used to in the old days we'd say restrict your protein, limit it. But what ended up happening was patients lost muscle mass, and that was much more detrimental to them than that slight effect of reducing the protein in their urine that they got. So we don't recommend that at all anymore. So we don't protein restrict anybody, whether animal or vegetable protein. So maybe not direct effects to the kidneys, but to overall health, there is data that vegetarian diet is better. And again, it has to all be taken with the quality of the data, as I mentioned, for dietary studies, is universally on the poor side, despite best efforts.
Thank you, Dr. Sood. Let me just see if there's any more questions. Okay, there's one. How do medications like hydromorphone affect kidney function?
Hydromorphone shouldn't. So hydromorphone is often the reason people are given hydromorphone versus, say, traditional morphine is the morphine-based compounds can accumulate in people who have reduced kidney function and can cause some adverse effects. Hydromorphone doesn't have that effect. So it shouldn't in itself directly affect your kidney. There are some pain control medications that can do it. The most common is the non-steroidal anti-inflammatories, or things like Aleve or ibuprofen. This class of medications can potentially reduce kidney function or cause kidney damage and worsen hypertension, but not the hydromorphone itself.
Okay, it looks like that was the last question that we had. So I will thank you very much. This was a very enjoyable session. So I will pass the mic back to Carrie.
Thank you, Julie. And I just want to take a moment to thank you, Dr. Sood and Sean, for your insights and your expertise that you've shared with us today. We've learned a lot about improving awareness of CKD. It's a great prediction tool that you shared with us. And knowing that the impact that awareness can have on not only adult patients who are at risk of kidney disease, but young adults who are showing early signs has been very instructive. I think we've probably all got something to take with us from this.